Good afternoon, friends. Uh, it's a pleasure. And at the outset, I thank organizers, my friend Dr. Bansi Sabi, to give me this opportunity. I'm going to speak on heart rate variability as a predictor of the cardiovascular risk in diabetes type 2. Yes, we know that heart rate variability refers to the bit to bit alteration in the heart rate, and it's a measurement of central autonomic drive to the myocardium, and it depends on a balance between sympathetic and parasympathetic drives to myocardium. So it's basically variations in time interval between heartbeats, and it is measured by variations in bit to bit. And when you see the average heart rate is 60 per minute, you can see that there is little variability in exact milliseconds as seen in the diagram. And this measurement is done either by using ECG recording or a polyplethysmograph or blood pressure curves. And ECG recording along with blood pressure curves is used normally as it is fairly accurate. If you see the autonomic regulation of the heart rate, the sinoatrial node, SA node generates beat impulses 100 to 120 times per minute. But the effective heart rate which we get is much lower, around 70. And why it is so? Because this is a simplified model of cardiovascular control which shows that heart rate generated by SA node is modified by parasympathetic and sympathetic system, and it is also affected by feedback loops from cardiac output, blood pressure, and renin angiotensin system as well. The variability in heart rate is due to synergistic action of two branches, sympathetic and parasympathetic, and which acts in balance through neural, mechanical, humoral, and other cardiovascular parameters like respiration, blood pressure, thermoregulation, and other influences, stress as well. And whenever there is sympathetic dominance, there is increased heart rate and there is reduced heart rate variability. And whereas there is parasympathetic dominance, there is reduced heart rate and increased heart rate variability. And so let us look at the big picture. Heart rate is under control of two systems as we discussed, and therefore changes in the heart rate over time provides a window into autonomic physiology. And analysis of heart rate variability quantifies these changes over time. And for that we have a methodology, and HRV analysis derived from RR tachogram. There are two methods, linear and non-linear. Linear is time domain and frequency domain, and non-linear is POP analysis. And you can see that this is healthy versus unhealthy heart rate variability. If it is constant, 1 second, 1 second, 1 second, 1 second, probably it is unhealthy. And something like 0.93, 0.98, 1.2, 1.3, and this is a healthy heart rate variability which we see. So this is a one variability which is good in contrast to our glycemic variability. So higher heart rate variability, less physiological stress, ready to perform, and lower heart rate variability, more physiological stress and tired or more diseases. So what are the applications? Heart rate variability can predict survival outcomes, and it has been investigated in several diseases like diabetes, CV diseases, myocardial infarction mortality, cancer, and neonatology as well. If you see the autonomic dysfunction in type 2 diabetes, we all know that hyperglycemia ultimately will cause many oxidant effects and lead to endothelial dysfunction, vascular occlusion, leakage, inflammation, and neuronal toxicity, and ultimately will lead to neuronal death. So, as a complication of diabetes, we have early and widespread neuronal degeneration of small nerve fibers, and as a result, there is a development of autonomic neuropathy. And as a part of this process, there will be ultimately cardiac autonomic neuropathy. We know that CV disease in type 2 diabetes is myocardial infarction, stroke, PVD, sudden death, arrhythmia, silent ischemia, and heart failure. And common mechanisms are atherothrombosis, arterial stiffening, microvascular dysfunction. But is it a complete picture? No. Another mechanism that is thought to contribute nowadays to CV disease in diabetes is diabetes associated cardiac autonomic dysfunction. And how do you assess this cardiac autonomic dysfunction. For that, you can calculate heart rate variability. It is a non-invasive measure, and low heart rate variability is a validated measure of cardiac autonomic dysfunction, and it is associated with the increased risk of ventricular arrhythmias and sudden cardiac arrest. Again, if you see the effect of diabetes on HRV, type 2 diabetes patient exhibited strong decrease in heart rate variability. Both sympathetic and parasympathetic activities decreased compared to non-type 2 diabetes patients, and which can be explained by the deleterious metabolic effects of blood glucose levels on HRV. And this is one study, systemic review and meta-analysis. And this study also reported that there is a strong evidence for overall decrease in HRV in type 2 diabetes patients. So HRV is a very early marker of cardiac autonomic dysfunction, and it is a subclinical marker of cardiac autonomic neuropathy, and so it happens to be easy and non-invasive test where you can initiate the preventive measure for cardiac autonomic neuropathy. Otherwise, if you see the clinical cardiovascular correlates of decreased heart rate variability, inducible ventricular tachycardia and VF, risk of sudden cardiac death, increased mortality in acute MI, congestive heart failure, poor survival in heart failure, post-MI survival, post-cardiac transplant, and sudden cardiac death in type 2 diabetes patients. And however, there are some pitfalls in understanding HRV also, because HRV reflects phasic, not tonic modulation of HR, and cannot measure autonomic tone, just a modulation of heart rate. HRV is like a black box. Decreased HRV can mean decreased autonomic input or a decreased cardiac responsiveness as well. And HRV cut points for risk stratification are best established in immediate post-MI period. What are the clinical implications? Normal HRV is a good negative risk stratifier. Patients with preserved HRV are low cardiac risk in absence of other significant risk factors, and sensitivity and specificity of a decreased HRV for immediate post-MI period is about 30%. So how can HRV be increased if you ask me? All lifestyle modifications, smoking cessation, weight loss, exercise, stress management, pharmacotherapy, lipid lowering, glycemic control, beta blocker like drugs, all will increase HRV. And HRV is important because it has clinical use, as we discussed, in myocardial infarction, hypertension, diabetic neuropathy, apnea, neonatology, and HRV is a very, very active research field also, and many research papers are coming out on this particular topic. Analysis of heart rate variability is a non-invasive method for identifying abnormalities in cardiac autonomic modulation, and decreasing HRV by itself is not sufficient to risk stratify patients, for example, AICD implantation. But HRV in combination with other risk stratifiers improves CV risk stratification in diabetes type 2 patients. So friends, this is my last slide. The HRV has got a future, and it is believed that heart rate variability will soon become as common in the patient charts as pulse, blood pressure, or temperature. And in the last 10 years, more than 2,000 published articles have been written about HRV, which is being used as a screening tool for many diseases, including CV disease in diabetes. And so, HRV can be used as a predictor of increased CV risk in diabetes type 2, but the idea requires more research for the standardization. Thank you for your patient listening.